what we were planning to do was do a bit more hands-on, how to do stuff today. So is that kind of what you were hoping for? Okay, so we'll run through how to upload, what the benefits might be, and that sort of thing, rather than the broader overview. Is there anyone else that particularly wants something else from this session? Because we're fairly adaptable and we can kind of match your needs. There is a couple of things I did want to say. There may be some confusion about how a My Health record would, in the healthcare home situation. We heard yesterday that we want people to stay in the healthcare homes, like belong to that home. And having a My Health record is good for sharing if you're travelling and going from place to place. The idea of all the patients having a My Health record is because the population of people that will be enrolled in the healthcare homes are chronic disease people, so they go to multiple care providers. Even though they've got the one GP home, they'll be going to a lot of other providers because that's what they do to get their chronic disease treated, and they might end up in hospital. So that's why a My Health record is really useful and beneficial for those particular patients. So does that kind of make sense? Anyone else have any questions about that? Was there anything else from the panel session yesterday that you wanted explained a bit further today? No? Okay, Katrina, shall we do... How many of you are actually using the My Health record in your practices now? Okay, about a third. So what we thought we'd do first is just think about why it would be beneficial to have a record, and just so that we do a bit of activity so we get going with a high energy. So Katrina? Well, come here then.
Hi everyone, I'm Katrina. I know it's really hard after lunch, so we decided we'd just start with a really simple hands-on activity and talking to regroup about why are we doing this? Why is My Health record really important for all of us? And the reason is because it's going to benefit our patients and it's going to benefit you all as clinicians in your practices. So I saw there was quite a few people who were here on Thursday. In the Thursday session, it was a 3-hour session, and we heard a lot of stories about how nurses are already using My Health record, and really interesting stories about different groups of patients. Are any of the nurses here today who are involved with the serving the homeless community in Perth that we heard from on Thursday? No? Okay, well that was one of the stories we heard on Thursday, or nurses who are working with people who are homeless, and how having information recorded so other clinicians who see them would benefit them. What we thought we'd start with, and Heather and I hear stories all the time, but I thought you probably don't, so it might be a good way to start to go in your practices, if you're using My Health record already, as a group, each table, just talk about how you see My Health record could benefit one of your patient groups. It might be that they don't have a home, they're homeless, or they're travellers perhaps. If you're not using My Health record already on your whole table, just think about what patient group My Health record might benefit. And if you could just write them, even if it's just one, on your piece of paper. We've even got prizes. So we thought we might have a bit of a, and they're not exciting. Please don't get excited. They're really not exciting prizes. And there's 3. I would really love to hear the benefits. A scenario. Who feels they've got a really good scenario that all other nurses would relate to? I was going to say that's probably all of you. Yeah, be brave.
We were just talking here about actually uploading advanced care directives. So this particular nurse goes through the form. The patient goes away, has a good think about it, comes back, they do the form there at the clinic and then upload it directly. Yeah.
Do you have any problem uploading it? Okay. Okay.
Design the process in your practice to assist patients with uploading their events.
Enthusiastically.
I'm not.
The challenge is that we can't just upload any document to my health record.
I don't know if I've got something positive to say because our table hasn't had great experiences, and you would know that there's about 800 practices being asked for their e-health payments to be paid back because they haven't uploaded the minimum amount of records. There's a feeling around this table that there's a degree of uninformation. Is that a word? Disinformation from at the practice point of view, but also from Joe Blogs in the street. Like my practice, for example, my patients just aren't engaged in the whole process, and I think that's just where we are geographically and demographically. So I sort of want to have a little bit of a conversation about how do you get the patients enthused, and therefore how do we become enthused at our end for it. So
if you were to think about your patients, and when I think about a patient in a practice, I think about our frequent flyers. I know their names. People who are at risk. So if you were to think about your patients, are there some in particular, a group in particular, who you feel are more at risk and would benefit from having this information?
it's all the obvious frequent flyers, the chronic disease patients, the complex medicine, and they don't necessarily have to be old people. They can be young people with who are in the disenfranchised boxes.
Okay. Absolutely. So, thank you. That's good. Yeah, and today's session is about going, how does it work? What does it look like? And how do we design workflows in our practice to make this work efficiently? And, I'm a trainer, as you heard, and I'm often saying, I don't have all the tips. I'm just really lucky because I actually am in 3 different practices a week across Australia, and I get to work with fantastic practices, award-winning practices that are doing amazing, innovative things. And the idea is that we work and we share ideas like conferences like this and go, would that work in my environment? And I'm glad you said the geographical differences, because all of your practices are different. Like even general practices, doing a lot of similar things, but we do them differently. So the idea is to go, how can we do it as efficiently as possible in our practice with the doctors we have and the patients we have, and collecting ideas to do that. On the website, digitalhealth.gov.au, this is what we do in education and training in Heather's department, is we collate all of these ideas, these case studies, we make videos, and we go, okay, well, that's for you to be able to go, how does it work? Because pushing the buttons is easy. I mean, when we talk about EPIP, 5 shared health summaries per GP in a quarter. How many medications do you change in your practice for patients in a day? You could do 5 in a morning. So it's not pushing the buttons that is hard. It is the rest of it. It's the education, understanding, patients' awareness, and building a workflow in your practice that's efficient. So that's what we really want to talk about today. I find and I've been training medical software and working in practices for 20 years, but I find with this training, my health record, it's about overcoming the barriers and the misinformation to go, how will this benefit our patients and practitioners? Keep your eye on your patients as you do this. When you keep your eye on your patients, it's overwhelming. You may have 100,000 patients in your practice. Where do you start? You start with those who are going to benefit, or you start with those who are easy. Those who already have a record are easy. Babies are easy. Who's in the Far North Queensland, Nepean Blue Mountains areas? Yes, easy for you in as far as you don't have the registration challenge. So what we'll talk about is who should we focus on as we move forward with this right now? Anyone with a chronic condition, of course, is going to also will have that relevance moving forward to healthcare homes. So these are all really great ideas so far. We've got a few more tables to go. Can I just get some more? Yes?
Oh, I'll go first.
Sorry.
We spoke about refugees and asylum seekers. A bit closer. And yeah, I guess the challenges with language, often quite a transient group, and just sometimes low health literacy, so that can come in handy. So I was actually sharing on behalf, I work for a primary health network, so we are in the process of working with a refugee health service to get them set up and ready to go. So they are only dealing with refugees and asylum seekers, so but they were really positive about it, so we hope that it'll be a success.
Yeah. I can relate to that. I've got a couple of practices I work with that, also have a big refugee patient population, and I remember clearly one of the GPs saying to me, I don't care about my patients who live in this suburb, and I won't name the suburb, it was a rich suburb. He goes, my patients who are refugees, I want all of them to have a shared health summary. This will be so beneficial to them. Obviously, many have such high health needs. So we do what we do because we're there for the patient. So that's the goal, to keep the patients in mind as we are getting patients registered and starting to upload that information. So that's a great idea. Yes? Sorry?
So we've got the old people, our older people, and we've got our chronic and refugees, but we also need to consider the well population who might end up in hospitals, young families and young children, which you said babies.
Yeah.
So, and they're quite easy because Mum will often register them herself once you let her know that it's something that is useful and beneficial. So you give the brochure or have 5 minutes discussion about My Health Record, and they've usually got a the my.gov account.
Yeah. Yep.
They have to register their babies, I think, through that now. I'm not sure what they do. But so putting their little ones on the register is really very good, and the immunisations can go on if they've had any illnesses as bubbies. So if they do go to hospital, then that's helpful.
Yeah, absolutely. And babies, I said babies are pretty much bored with a My Health Record now, because when you have a baby, they say, would you like a Medicare number and would you like a My Health Record? And I always laugh because, I'm not young. And I go, imagine now to a young mother going, would you like an online summary of your baby's health information that can travel with you anywhere? Or would you like this book to carry around for 5 years? So to me, it's like, of course they're going to want that, and they're going to want an app, and they're going to track there. I can imagine I would have written everything in the app when I had my babies, including my own personal notes about that. So
so have a look at your babies, because most of them from under 4 will be registered because the form has been changed for about that many years. And also on the work plan now, some of you may know in New South Wales they had the Blue Book that was you could get an app and it was uploaded to My Health Record. That's now working across the country. So there's a working group to get a early childhood record. So once the kids are registered they're trying to get it from antenatal for the baby all the way through, so that, when we get genomics and all that business, they'll be able to go back and have a look at their antenatal records to see, how much care did they have, or did they have any issues in the pre-birth stage, and is that why they're misbehaving at 12 years of age or something. So they'll be linking those things together pretty soon. So that'll be happening. There's a group already formed, and they've started the working group. So that'll, in the next 6 months, just watch this space, because that'll probably happen. Now, we've got time for some more stories. One more story.
Sorry. We're in Ballarat, and about, as many of our older people who can leave. They all caravan up to Port Macquarie region. and most of them do, in fact, have two doctors. They've got the one in their hometown in Ballarat, and they've got their one in Port Macquarie. Most of them come back and they will have spent a certain of their 3 months in Port Macquarie in the hospital up there, and they also visit the base in Ballarat, and so I can see a real need there because we know they have two sets of medical needs.
And that would be about a good 20% of the population, don't you reckon? Across the whole lower part of the country, yeah.
And my parents live in Port Macquarie, and I just worked in Port Macquarie, and they told me they spend 2 hours a day chasing information. So that is, and sending, chasing or sending. So phone calls and faxes to get that information when we could do, as you will see here, we could do one click. If those patients are registered and they have, when you see them, whatever software you use, it will be green because that was one of the usability improvements. When you see that they have a record, however it looks in your software, you will go and look at that. What are you hoping to find? What sort of summary? Yeah. Allergies, medications, medical history. Have they had a tetanus shot in the last however many years? That's what document is that called? Shared health summary. So those of you who are new to this, a shared health summary really is literally just 5 things. Demographics, allergies, medical history, medications, immunisations. Those 5 things we need to know when we see a patient for the first time. So if everybody travelling had one of those, you would be able to have a look at that, and you could potentially also then, they're allergic to bee venom, good to know. You could also, as easy as one click, save that in your software. So that, I'm always saying to people, my health record is not different to what we do now. Right now, we chase information to get that. It's faxed over. It does a little journey around the practice. Everyone looks at it sometimes. And eventually it gets scanned in, which is a whole lot of work. And for practices, it's a whole lot of wasted money that they are paying somebody to scan that in. When we could, if we were being, tech savvy, we could just do that. You have it, look at it, and move on with the consultation, hopefully knowing information you didn't know before and saving the patient having to tell their story over and over. And you check it with them. Yes? Yeah. No. Yeah. No. Yeah. And that's a good question, because what we're talking about with what you're asking is atomized information. So when we take, for example, medication and it goes into the medication section in the software, when we take the allergies and it would actually go into that allergy section, that's atomized information. We're not at that stage yet, and that's because, it needs to be checked, and that's not something when it was at this stage what people had wanted. But Heather will say more on that.
But I will tell you what is happening at the next release, which we're calling Release 8, which is irrelevant to you, but it just means we're up to 8 releases. That works, doesn't it?
Yeah, makes sense to me.
Is what's going to be called a medication view. So when you go into your document list, so do you want to do that? So the first thing that will come up in the document list, so as soon as you go into your software and press My Health Record, document list, you will see what's called a meds view. So you'll see every medication that the patient has. So their PBS information will come up, any medication off their shared health summary, any medication off the discharge summary, providing it was structured data. In some states, like some of New South Wales, is coming up as narrative, not structured data. So you'll have a link to the discharge summary to say that there's medications in there that aren't on this list. So you just click on there to see what the medications are, because they're different to what you might have. So it'll all be in a row. So because medication history is one of the most important things for the patient, so that I think this is one of the best things that we've done. So we're starting to do clever things now. So you will see, and you'll also have a link to the latest shared health summary and the latest discharge summary. So you'll just click on that through the medication view. So if there's an event summary with meds in there, it'll come into that view, but you won't have a link to it. I think that's starting to make some use and be really useful for the clinicians to look at.
Yeah, and it's a really good point, a really good question that you raised, because I think for the first 3 years, I was literally just training doctors all the time with this. So as you can imagine, everybody has feelings about this. In the early days, there was a lot of concern, and every now and then a doctor would say to me, but that's just a dumb document. I want it to do more than that. I don't want it just to sit there. I actually want it to populate my software. And I'd go, well, hang on there, because the idea of what you're saying, has a lot of merit, and that's the goal, to be able to have that view. So when you get perhaps your doctors or people in your practice saying, why can't I just upload this document? Why can't I upload this PDF? Why can't we do care plans in 50 different ways like we have in our software? It's because then we're limited to it's just a dumb document. Whereas what we want to have is that benefit of a medication view. For example, that's hugely beneficial, rather than having to troll through 3 documents to get a picture of, well, that medication's on the discharge summary, that medication's on the shared health summary. So that's why this is a massive build. We're talking about a national shared electronic health record. And, we're doing pretty well in Australia. It's a huge, like an ecosystem. It's one of those things that's a lot goes on, and every single step forward, there's a huge amount of considerations.
Sorry, when you look at that document there, that's in what's called a clinical document architect. That's a technical terms. We call a CDA. They take quite a long time to build. It's like a PDF, but there's new technology now called FHIR. So we're starting to use that, which is much more speedy to get from development. So you will see the ability. We'll have much better ability to start producing different documents. So when we're talking about a care plan, for example, we will only do a care plan with some data elements. We're not going to create, like your templates, hundreds of them. But we're able to do it much faster now. And so, we'll see a lot more, and especially with apps and the development of those sort of things. And as I said the other day, we're going to be co-producing, so with clinicians and consumers and vendors. So things will be developed back here, what people actually want. There'll be a lot more consultation, and then at the end, testing to make sure it's right. Like the medication view that we're using is being tested currently after it's been in production to make sure it's right. So when we're looking, the stage that we're at now, when we're looking at those My Health records, I don't want to set anybody up to fail, basically. So just be aware that there isn't a lot of information on there yet. So that's one of the key things about the patient's team, as I see it. We need to upload shared health summaries. Who's going to benefit from looking at a shared health summary for your patients, your frequent flyers? Hospitals, yeah? Who else? Patients, specialists, the doctor in Port Macquarie, pharmacists. So it's really about, we haven't done a great deal in general practice, and general practices have struggled to upload 5 shared health summaries in a quarter, some of them, and now they have to pay back money they got for doing that. So we haven't put a lot of information on it yet, but that's changing by the day. And the EPIP payment was very successful. And I tell you, if I have to train when I've got allied health professionals in the room with GPs,
it's not a nice feeling because they don't get any incentive payments at all. So I actually think the EPIP is a good thing. We get it, we need it in our practices. The bar is very low, but I actually am very passionate about when that doctor sees the patient in Port Macquarie, being able to see that and to save that elderly patient from having to tell their story over and over again, and instead they just check it with the patient. And then they can save it, which saves the phone calls and scanning. So it's not dissimilar to what we do now, it's just more efficient. Right now, we would generate a summary, and if this was, and I know this is medical director and you probably all have different software, but it's similarly easy, and I'm going to show you how you can learn how to do it in your software. But in medical director, at the moment, we would generate a template or a summary in here, and we would print it out, and we would give it to the patient. Or we would fax it. So what we're talking about now instead is being tech savvy, going, well, I'm going to do a shared health summary. If the information is collected in the software for those 4 things, I won't count the demographics. What were the 4 things? Medications, allergies, past history, immunisations. Really, the 4 things you need to know about a patient if you're seeing them for the first time, what ED needs to know, what they ask over and over and over again. So if that information is collected, you hit the little, it's actually, this is an older version that I'm looking at in here, but it says little My Health Record symbol now. That information will be collated in that CDA format. So it's sort of a document view that we'll get very familiar with looking at. And I find doctors like it because they don't, you can see with referrals, you can't see the wood for the trees. It's like, where's the important information? With this, it's the same way all the time. Allergies, medications, medical history, immunisations, and you hit send. Now, who's uploaded a shared health summary like that in their practice? Great. How long do you say it took? Yeah, thank you. Yeah, so once you get the hang of it, and how many times do you think did it take you to get the hang of it? Yeah, excellent. Yeah. So I was with a nurse, a fantastic nurse over in Denmark, doing some training, and she didn't really like computers, you know. As I say to anyone who'll ever listen, I've never met a nurse or a doctor who chose medicine because they like computers. You know, it's just secondary but essential these days. So they were registering patients in the practice, and she'd registered a mother and her children, and the mother rang when she got home and she was disappointed. And she rang the nurse and she goes, I just had a look at it and there's nothing on there. And she was disappointed. And the nurse said, well, come back in and I'll upload your shared health summaries. So she went, quick, Katrina, I need to learn how to do it. So she went on to this test environment, exactly the same one I'm on now, and I'm going to show you how to do that. And she uploaded it by herself. I was watching. And then she went, okay, I can do that. So in this, I think it was medical director as well. So, she went, I'm going to do a new letter, a new e-health. So she went to e-health. She went to shared health summary. She went, that's it. That's good. That's correct. She hit the little E or the little, now these days it's a symbol of My Health Record, and then she hit send. And she went, okay, I got that. And then she went, I'll do it again. She did another one. And then she went, I'll just do one more. So she did 3, and then she went, okay, I got it now. So I think that's a really good indication. And if you, as I imagine, you're all here, so it's you're tasked with going and training everyone else in your practice if they're not yet doing this, because that's the whole benefit of going away to a conference and learning and sharing your knowledge. Yeah? So that's an indication to me that for people who aren't computer people, you know, they don't love the computer and spend all day going, what's this button do? 3 times is really about going, I feel confident enough to do this with a patient. And remember, I've spent the youngest, most IT savvy registrars I've had say to me, Katrina, can you just sit with me while I do this first one? None of us want to do this for the first time with a patient. You want to feel a little bit confident with what you're doing before you get the patient with you. Yeah? So, yeah. Great. And that's what happened when it first started. Whose practice have they done their own? Yeah, I'd go around to a practice pitch and stuff would relate to this. It was either the practice manager or the principal GP. That was what was uploaded. However, at the Digital Health Agency, what we did was we created a test environment, because who's got a patient in their database called test? Yeah. You got dummy and the dummy family, yeah, and they've got every condition. Yep. So you've got, yeah, it's how we work. It's how we learn the software, yeah? So with this, for the first time, we didn't have that. We didn't have dummy or test patient to practice on. And that's a significant gap. This is scary as all hell. You know, we're now asking doctors to share information not just with one other doctor by fax. We're asking them that this will be potentially seen by any other clinician treating their patient in Australia. I think we underestimate that change. That's huge. From a patient perspective, it's hugely beneficial. But I've been working in practices 27 years. We've controlled what information we share for our patients. We certainly didn't give them access to it. If we did, it would be, okay, you can have this bit. Now it's a new world. Patients Google you before they come and see you. They Google their conditions. They Google what the results mean. So who thinks it's a good idea that patients know their medications, past history, allergies and immunisations? I never have any trouble with nurses understanding that. It's about empowering them and health literacy, and hopefully they'll be more engaged in their own health if they have that access to information too. So you don't have to, I'm going to get it out of this altogether. You don't have to now do your own. You can go to digitalhealth.gov.au and you can actually practice in that test environment like I am. So I want you to also know that because Heather and I like to go with whatever you need, so we want it to be interactive. We want you to ask us questions. We will go here if you want to go here. In the presentations that we create, there's like 72 slides. Okay, they're like little e-learning things. So you can actually go from here to here. So if you're brand new to this, what is digital health? Every step for viewing and uploading in every software is in this presentation. The links to look at every website is relevant. The cheat sheets, the videos are in this presentation, which APNA will have on their website. Yeah. No, you choose. You choose what's shared. Yep. So it's not dissimilar to, for example, if a patient, you're referring a patient, and the whole, hopefully, idea is that past history will go on a referral. And sometimes patients do not want that information shared. So certain sensitive conditions, and when we talk about this, I always say, have an idea of this, but don't assume. Because it's up to the patient at times what they regard as sensitive and what they want shared. And I learnt my lesson because I work with a GP who's like an ageing with HIV specialist, been doing it for 20 years, and he goes, "Oh, Katrina, my patient," and I had this thought in my head about patients with HIV may not want that shared on their health summaries. It might be a conversation, for example. And he said, "Oh, my patients with HIV, absolutely, they see the importance and necessity of having that shared, but they may not want syphilis on there." So this is where it is a conversation when uploading. First of all, is it accurate? Is that past history list in your software accurate? And then, is the patient consenting to have their health summary uploaded? And one of the things with that I think I can safely say no GP has ever liked is the fact that patients can remove that shared health summary when they log on to their own My Health record. Pretty sure I can say never met one that's like that idea. It's a bit, But I say to them, if I was with you, and I just did this a couple of weeks ago with my GP, went through the whole shared health summary, discussed it. She educated me about, that's why that needs to be on there. If I was with you, why would I get a shock when I saw it, when I logged on, and remove it? But if I wasn't with you, I hadn't seen you for 18 months or a year or 6 months, and all of a sudden my shared health summary was uploaded and it was wrong, I might want to remove it, and I might also be a bit annoyed. So I also train for the indemnifiers with them. I hear them in my head daily when I'm with them. I've heard them say many times, most of the complaints come from patients not knowing what we're doing and why. The more we empower them, we communicate. Let's have a look at your My Health record, shall we? Shall we upload a shared health summary? Should you need to see another provider, that information will be available. Are you still taking those medications? Is this accurate? Of course. Oh, it's a conversation, doesn't take a couple of seconds. Yes. I know. No. And I think everyone I've ever worked with who's done this will, the conversations, and depending on the patients, that could be a prolonged consultation. And depending on the complexity, it could be a longer conversation. I think ideally, initially, they should have that conversation. It depends on the medications. Doctors are the ones who have to go through that medication list. And as team care providers, that's the bit that I often can't help you with, because I'll go, well, at some stage, the doctors are going to have to go through the medication list. At which part of that? Now, has anybody got anything that you would like to share in your practice when you're uploading a shared health summary? What is that workflow? Do you see them first? Yep. Oh, yes.
First.
Yeah.
And
great.
So make sure, and any time I do a GPMP or a health assessment, I do that before I do anything else, and just delete lots of rubbish.
Yep.
But I'm not saying our GPs, it's from the past, way back.
Yeah.
From, when IT was first starting, some of it's just left in there because the doctors don't have time to clean up other doctors' work. So.
Yeah. And really, until now, they could have been using this software for 15 years. Until now, they've been able to use it any way they like. And now all of a sudden we're saying you have to use it this way. You have to choose from a coded list, that diagnosis, and you have to extract information. We have our chronic condition registers that are coming from that information. We have health summaries. We have care plans. So it is a shift to this technology is vital to our practice management and our chronic condition management. Whereas for many, many, many years, you could use the software however you liked and write however you liked. And now we're forcing people to say, no, I need you to have this accurate. And for our help with that, we have things like the accreditation standards. I mean, these are the drivers. The standards say we have to have a health summary for our active patients that is up to date. We have to share information. We have a responsibility to ensure that what we're sharing is accurate. And I like the fact that the new PIP changes are based on this data and improvement and quality. Because as you can imagine, having done this, I've been teaching how to enter information and clean it up for many, many, many years. And I feel at times like I'm banging my head against a brick wall. So everything that we're talking about, the healthcare homes, the PIP changes, the accreditation, I love it because it's driving quality information. And when I'm being really cheeky and a bit frustrated, I will say to doctors, I cannot give you an invoice that is 50% correct. Why? Can you print my medication list that's 50% correct and give it to another doctor about me? That's the reality. We haven't had that standard before. Hopefully, digital health is going to mean we're looking at what we're sharing and not uploading 15 years of rubbish. And it's not their fault. The software didn't help for many of those years. It accidentally duplicated reasons for visits if we don't use software well. Data quality is a big part of the presentation that we've got to share with you today. And one of the first things I did when I joined Heather was create a 5-step checklist, data quality checklist that I was recommending everyone put on every doctor's desk. And every time there's a practice nurse in a practice, the standard of that health summary information is improved. So I thank you all for helping with that. At which point does the doctor clean up the medications? Is it after you do the past history cleanup or at what stage?
To do that. Some practices, the nurse is confident enough to do that and skilled enough. But if they're not, you let the doctor know that it needs updating because they just don't review it. And there'll be old medications from years ago that the patient's just not taking. So I go through every single medication on the list, and sometimes the patient says, "I don't think I've ever had that."
Yeah. Wow.
Okay. So yeah, and I will so do the medication review, but I will also type a note to the doctor, either within the notes, so it's quite clear, or if it's if I don't want it to be kept in the patient's record, I'll just send a pink note on the desk to the which is in the communication system to the doctor to say, can you please check medications. Yeah. And it has cleaned it up a lot, I must say, by doing that. It takes time because you're going through a medication list with an elderly patient. But it's worthwhile because then when they get their history printed out or their health assessment or their e-health summary, it makes sense.
Yep, that's right. My 78-year-old mum looks at it on her Healthy app on her iPad now. They cannot participate in digital health or accreditation or keep going.
We do participate in accreditation. I've had the practice accredited 3 times since I've been there, but prior to me being there, it was just nothing happening. But the others are using electronic scripts, but he just refuses to. Yeah. And it's so frustrating.
Yeah. I see that quite a lot. I work with practices often that have 15 to 30 doctors, and they'll be the complete spectrum of, doctors will say to me, what do you mean I have to double click, Katrina? Can't I do it faster than that? Haven't you got a shortcut so I don't have to double click? And then I'll be in the same practice, one who doesn't use the computer at all or will just be doing scripts. So that's the challenge of the practice manager. I see it to gently move everyone forward with change step by step. And that's what they do. And that's where the team approach to ensuring that, you can still work efficiently with that. Yeah, unless they're ready for retirement, sometimes it's literally about, okay, finally they do have to give in. But one of the things that I just wanted to show you is, and this will help with that, is sometimes a little bit of training and a little bit of time to explore without that pressure of somebody with them can help as well. So this on-demand training environment, this is the digitalhealth.gov website. This is your go-to website. So all of our training resources that I was mentioning before, all of those videos, software demonstrations, case studies of what other nurses are doing in practices and other innovative ideas are in here as well. If you're brand new to all of this, this is how you start the apply for digital health and getting your software connected. If you want to see if your software product is able to be easily integrated, like Medical Director and Best Practice and ZBed and Genie are, and others, that's where you can see this website as well. But this is our favourite place, or my favourite place, the sandpit. So where are the PHN staff here today? How awesome is the sandpit? It means that you can demonstrate to others in a practice. People can practice in privacy. I always say set it up in your tea room. And on the left-hand side, there's quick links to those other training resources. So as I said, the software environment, software demonstrations. So I'm doing it live today, but when you go back, you could actually watch the software demonstration and print out the cheat sheets. I think that's a pretty good plan. Watch the software demonstration, print out the cheat sheets, and then go into this on-demand training environment and practice. What we have now is we have also a consumer portal simulator. So this is really helpful. Who's got their own My Health record? Hang on, let me see properly. That's great. I mean, I feel strongly that if we're talking to our patients about something, we should have a pretty good grasp of what we're talking about. I would hate to think anybody's talking to patients about this that hasn't learnt from the correct places, because there's a hell of a lot of misinformation out there, constantly correcting it. So this is, if you don't have your own, if you have your own, I would say log on and have a look at your own. Have a look at the privacy settings that you can set so you can reassure your patients. Is anyone from a little tiny country town? Yeah. Sometimes people in little country towns, you work in the same practice. You see the doctors, you work there, you live there, you know everybody. Often people have said to me, well, I actually would like a little bit more sense of, security and privacy. So you can set that privacy. I have mine set so I get an SMS alert if anyone accesses it. But you could actually set it so that you have to be with the clinician and give them a PIN number. And there is a safety setting on that. If you are unconscious, they can break glass. And the worst that's going to happen is you would know that ED, for example, looked at it. Yes? Yep. Yeah. Yeah, that's right. You're in a specialised group. So for you, it's a really significant issue and a significant focus to consider, which is absolutely right. And others, I've had others, like sexual health clinics is another one. Treating really young people is another one. There's a whole lot of, what do we call them, Heather? There's hard to service, there's hard to reach, so correctional facilities, patients in correctional facilities, hard to service. And so these are absolutely issues that come up for practices, but for you, it's more significant. And it is about saying, how is this going to work for our healthcare service? That's why when you do use My Health Record, you need to have a policy for your medical service, and you need to have staff training on how it's going to work. And for you, it'd be considering all of those issues around consenting and also registering, because if you are registering patients who don't have capacity, that's a whole completely different ballgame, which is one of the reasons why I always encourage people, if you can, please register all your patients before they lose capacity for your elderly patients, because that would be wonderful. But yeah, so it's not, and again, it's about assumptions sometimes that we make. Only healthcare providers providing healthcare for that patient can access their My Health Record. There is an audit trail of access. There are significant, serious penalties. It's a criminal offence for serious and malicious what's the term? Thank you, misuse. Thank you. So it is possible, but it is, serious if that is something that happens. And the benefit of computers is we can see, well, they can see.
Yeah, I think you're absolutely right as well, because it should be informed consent. So you need to make sure that if you are registering these people, they actually know what it's about and what the implications are. And the same as if we do go opt-out, there's a whole lot of work that will happen around how to inform those people. And that's starting to happen behind the scenes to make sure that, we can't be accused of giving people a record and then sharing their information without informed consent, because it's just not correct. No, it doesn't have to be written anymore. The forms that you fill out, you don't have to get a signature, but a lot of practices are getting it signed still, so that they can see that the patient actually read the information, signed it, and a lot of practices are still scanning that into their records. So then if they ever come back and say, I didn't know I had a record, you can say, well, actually, we gave you a pamphlet, we gave you a form, you filled it out and you signed it. So, they do have it is informed consent. It's very important. And as much as we'd like the whole country to have a record and not tell them about it, I don't think that's ethical.
And then there's having a record, and then there's uploading to the record as well. You need consent for both.
Yeah.
Once they have that, you have standing consent to view and upload as their healthcare provider.
And
but
there's
initially,
very tricky situations. What about in the disabled home care? Where you've got community houses. How do they work? So we'll be working with NDIS to work out what their sort of consents are and how they're getting that sort of information. So. What's that? Dementia as well. Sometimes, they've all got guardians, which is the state. So, and some of that is about what's going to benefit those patients. Obviously, if you're in a nursing home and you're not going to go anywhere, you don't really need a record. But if you're going to end up in a hospital, you do need a record. You do need to share information about what their ability is and what needs they'll have when they go somewhere else. So it's what's in the best interest for the patients as well. I mean, you're already doing that by paper now, so it's kind of just an electronic form in some cases. But it is really important to make sure you do get, as much as we want everyone, as I said, it's got to be informed consent.
One of the important things I think that's reassuring to patients is that we don't upload all those little commentaries about what we've talked about today, in their notes. It really is just those basic important lists of information, their medications, their allergies, what we were talking about. And I find that that's often reassuring for patients to hear that, we're not talking about my boil on my bum today. It's not going on my health record. It's just important information. I found for some of my patients that was reassuring.
Yeah, chronic conditions and significant events.
Yeah.
And that's I guess a training thing with the software generally. The past the past history list poorly named, really. It is chronic conditions and significant events. It's very different from a reason for visit or a reason for contact. And that's the challenge of just using the software, and that's the data quality challenge that we are all, I think, in at the moment. It's good to hear there's been some major work done on that. Operation. Yeah, an operation, hip replacement, any operation really, I would class as a significant event.
Or a childhood illness that has an impact, like rheumatic fever or something like that, that might have an impact on your cardiac output later.
And that's going to be a significant inactive condition. So, and I had rheumatic fever as a child. Everybody wants to know about it. Every time I see a healthcare provider, it's like bells ringing. And then in the comments, it says, last echo 2000 normal. So, and that stops the conversation. So having a shared health summary with that simple, significant event on it communicates with other healthcare providers. The comment or the detail that goes with that past history item means it's a more effective way of sharing that. And that's if you, for example, had a patient say they had schizophrenia. What is the name of the specialist, the psychiatrist who cares for that patient? A shoulder replacement. Who was the surgeon who did that operation, or the hospital? So that if you saw that patient who had that condition and they were having trouble with it, maybe they're in Port Macquarie on holidays and it's like, my shoulder, and you're like, what was the operation? You know, at least you can see what it was and who maybe to contact for further information.
Yeah, and if you've got past medical history, for example, say I had 5 or 6 terminations as a younger woman, now that I'm this age, it has absolutely no relevance. But if I was still at childbearing age, it would be relevant. So, you know, you'd leave it off my shared health summaries now, but you might have put something, not necessarily that, but you might have just had, you know, some indication that they'd had some abortions before. So just think about the past medical history and when it is relevant and when it's not any longer having an impact on your health. That's the sort of stuff.
Yeah, it is. And that's where a conversation with you, and that's an opportunity for education. As I said, I was educated by my GP about this a few weeks ago. You know, it is about the patients knowing, and they are consenting. And again, with the medico-legal voice in my head, I hear them saying, if a patient is ever asking you to do anything that you feel puts you or them at risk, refuse to do it. Nobody has to have a My Health record. Nobody has to have anything uploaded to it. It is a consenting process. And I find generally, if we do educate well and we empower the patients, they want one. And the evaluation from the 1 million people who are in the trial sites would indicate that, because very few did opt out. But what I learnt from being the trainer on those trial sites is educating our patients is a major challenge for us all, because we want them to understand what this is and how it could help them.
You talked earlier about 5 easy steps to clean up the data. Do you
Yes.
have a slide on that one?
Yes,
Thank
I
you.
do. I have a slide, I have a link, and it's also on this website. So what we have in here on the on-demand training environment is all these training resources. Okay, so it is in here, but I've got a direct link on my slide, and I'm going to show you, but I'll show you how it is in the software. So when you can look at the consumers, see what sort of settings they can set, and that would be handy if you guys don't want your own My Health record. But this is the sandpit, the on-demand training environment. The password is written there. Who uses best practice software? Medical director? ZMed. Jeannie? MedTech? Communicare? What else have I missed? GP Complete? Stat? Okay, so as you can see, there is a lot of different software. If you can find out on here if your software is conformant. These ones you see on the screen here are the ones where... Oh, thank you. That threw me. So you would go into there, and that's where, so we were a medical director before. So this is what I wanted to show you. This is exactly where I was before, and this is where you would go and practice. So regardless of whatever software you have, look at the videos, watch how this, as I'm doing live, watch it again, then go in here and have a practice. Get everybody who is going to be uploading, give them the opportunity to have a practice, whether or not they want to do it with you. Bear in mind, if I could share anything, that's what I've learnt. If people are very resistant to this, find out why. Often it's a matter of misinformation. I have doctors quoting the headlines of articles, newspaper stories to me all the time, and the information is actually inaccurate. I mean, the truth doesn't make for an exciting story, is something I have learnt. When I read the articles, I'm like, actually, no, that's not how it works at all. So this is the patient is Caleb Darrington, and that information comes up on the right-hand side, but I'll move a little bit faster. So the idea is that you go into here and you can have a practice. What you'll see, and this is now best practice, but what you'll see on the left-hand side is similar to all your software. It's just in a different place. The data cleansing, as we call it, the medication lists, the past history list. If their depression is no longer active, it might be something that is still, of course, helpful to share if the patient agrees with that, but it's now an inactive condition, and it may be, when was the last episode? The last episode was in 2013. What other detail about that condition might be helpful to another clinician who sees this patient who's not known to them, to an ED department? This further detail is gold, because when I have doctors say to me, I can't code the condition, it's not on the list, I say this is a national list. We have to code. It's part of our general practice standards. It's part of accreditation standards. It's part of good chronic condition management to build registers. We need to code. It should be on the list, but then I do work in the real world. Irukandji syndrome, I was looking for it, wasn't on the list. Had patients with Irukandji syndrome, nasty little stingers, poor patient. So marine stings on the list, and we put the detail of that. How helpful. All of those patients were travellers who got stung. So this is really helpful if you are trying to work with your clinical team with that change management, because not having this list coded and accurate will affect your whole entire practice management. Cleaning it up, deleting what is not a chronic condition or significant, does not delete the progress note in which that information was originally collected. Deleting a medication does not delete it from the software. It puts it in another section, whether that be called past prescriptions or old scripts. Doctors like yourselves never chose medicine to work with computers. I cannot tell you how many doctors I have trained who did not realise something was in the software. Every single day of my life, people say to me, I never knew that was there, which is wonderful to me because your focus is on the patient, as we want it to be. So don't assume, is my advice. Take back all the tips that you've learnt, about this. Show the presentation that I haven't gone through it all. This one that I spent all that time on. Because within this presentation, we've put links. We talk about the big picture, about why we're doing this, because our patients do see multiple healthcare providers. When you use and upload as general practices, that a lot of you are, you would be uploading a shared health summary. If you have cleaned up the data, it is literally less than 20 seconds. Practice will work me. if you were, and I'm thinking of your example, perhaps you're not doing the full range of general practice, it might be an event summary that you're uploading. So an event summary, they're not the regular patient, they're the doctor in Port Macquarie that sees your regular patient. What did they do? So it is a choice. I just think, wouldn't it be wonderful if every after hours doctor uploaded an event summary for your patient? And the example that we also have from Heather and I, okay, I can't see that, but I think it's at 10, was, do you want to tell the story about the oncology? Uploading them, yeah.
In a clinic in WA, there's a whole bunch of oncologists who are uploading event summaries for what they're doing for every treatment. They're getting all their GPs of all their patients to put the shared health summaries up, and they've got the pharmacist in the private hospital uploading what the chemotherapy protocol is. So how good is that for a patient who ends up in the emergency department? Because even at the major hospitals like St Vinny's in Sydney, the cancer care unit is all computerised, but it doesn't link with the hospital. So, you know, everybody's on protocols, but, you know, those are the people that get infections and end up in emergency departments. So this group, I'm sure it's the nurses that are uploading it through Jeannie, but it's the oncologists that wanted it happening, which is fantastic.
Yeah. And if you have a patient who has cancer, for example, they will have obviously a much more complex health summary than someone like me, for example, who has one allergy, one medication. My information should be there. It should take 20 seconds to upload my shared health summary because that information should be in my file. So I can't be charged a long consultation for that. However, anybody who is, you know, our high-risk groups who are complicated, if that is a long process to ensure that that information is up to date, you can charge a long consultation for that. And I have a friend who's had leukemia and had a stem cell transplant, takes 23 medications every day. That's the patient that I think of, yes, you're going to make sure that that information is accurate, but how beneficial. She has to manage all of that herself. I couldn't tell her story if I had to. It's that complicated. So when you're doing this, focus on the quality of the information and the patients who are most likely to benefit should they need to see somebody else. Yes.
The event summaries, can they be done by, say, nurses? I was just thinking of a scenario where maybe you don't have a GP on board and you would really like to make a note for a patient. You have consent, but you're not happy that, say, maybe the medications haven't been tidied up or something like that. Can you as a nurse do an event summary?
Yeah, absolutely. That's a great example. We've had it was the outreach clinics, the midwives in the outreach clinics. You know, they're people out there in outback New South Wales, those poor patients never even see a doctor the whole pregnancy, and the nurses go out there, they're uploading event summaries, and that communicates with the town when the patient does present.
That's right, and in some areas they're using the event summary as their antenatal documentation, because we haven't got an antenatal record yet. We will do, I'm sure, but at the moment they're just putting up an event summary for each visit, because what happens in the event summary is whatever your progress notes are, it'll upload into the clinical synopsis, and then you can edit the clinical synopsis. So you don't, whatever you write in your notes, if you write this person's a cow or something, you can delete it once it goes up onto the... it's the same...
Yeah, so like this, exactly like this. So say, for example, in today's visit, or maybe you had, you'd done all your observations, or I won't do a whole visit, obviously, but I'll just do one thing. So you've done an observation in there. Everything that you do in today's, progress notes. So my health record, event summary, but think of it like, so I can import today's progress notes. You can tweak it So if you don't want it to say something, if you wrote information given on something, you don't want it to say that, you can take it out. Importantly, this is related to that event. So if the patient, elderly patient who was seen in Port Macquarie, they might have had a fall. You might have given them tetanus. That tetanus would have been entered into here. It will automatically go on to here. Any medications, antibiotics would go on to there. So when they next go to their next town, should they need to see another doctor, they can see what happened in the last visit. And this is where we can also share results, and we talk about documents. That is possible to go into there, but eventually we'll have the actual result on the My Health record.
And see the more button there. If you press that, you get, no, go up to the something else that's got information. Yeah, so there you'll see the other immunisations, and they're unticked. So if there's one particular one you want to keep in there for all the time, so somebody else who looks it up that may not be looking at the shared health summary, you can do that. So you do everything that at that particular event comes up, and then there's an opportunity to add a bit more from the notes if you wish.
These are investigations that are received at the moment directly into your software.
Yeah.
In addition to that, what we will have is investigations done elsewhere.
Remember, we've got our own trial database. It's not a real patient like you. So we probably haven't put it in there. No. Yeah, that's right. It'd come up. It'd be, yeah.
Yeah. So just the latest ones.
And it'd come out of your system because you've got it in there, but we don't have the results. Yeah, that's right.
So we have, whatever software you use, we have a simulation. So you can just watch a video just like this of what we're doing. We have, thank you, cheat sheets. I couldn't even make them 5 steps. It's literally that. Upload. And the refugee clinics use event summaries too, more often. That's a shared. Yeah. So the event summary and the other documents that you have also, as you said, the advanced care directives, you have the patient's MBS, PBS information, the AIR immunisation. So we do have a lot of documents. So it'll say event summary, and even knowing who it was that they saw at that last visit. So please have a look, get the presentation, have a look at the slide. Look out for your patients who have green in your software. If your software is not connected, then go back to that stages of applying and start to have a feel for how it works in the on-demand, and then think about which patients would benefit. Yes.
And I rang Medicare, they couldn't help me, they had no idea what I was talking about. So what do you do in that? Because everyone's supposed to have an IHI.
That's right. So what you would do in that case is, the first question I would ask is the Medicare eligibility check working? Because what we want to make sure is that the demographics, so this is number 1 on the list of 5 things, the demographics have to be perfect. This has been built with bank strength security. It is a tough match. We can't be, it's Jack Smith if his name's Jackson. It has to be Jackson and his middle name and his surname. So sometimes the accuracy isn't perfect, and sometimes, dare I say it, just sometimes Medicare has their information wrong. Okay? Yeah. Yes.
Thanks so much, Heather, and safe travels. So You're happy to stay for a bit longer?
Yeah.
Okay.
Just 1 second before I take your question. It may go opt-out on Tuesday night. In the trials, there was a percentage of patients whose IHIs didn't match. If I could make a suggestion, get your patients' IHIs now, because even if 1% of your patients don't match, they've been told they have a My Health record, they're going to come into you, then it's going to be chaotic at that point. We can just gently prepare for it. That's much nicer than just having this, oh my goodness, I have 100 patients whose IHIs don't match. We'll just start matching for every patient in your database as they come in. Yeah. Yes?
I was just my question was about when, say you've got a grey nomad that's gone around Australia, 6 months later they come back to see you and they've had 6 event summaries put up. When we go into the software, how do we view that, and is there going to ever be the opportunity, or is there now, to, if say their medications have been changed, if they've seen a specialist or they've been away, to input that back into the software?
Yeah.
Rather than actually having to,
re-enter it. Wouldn't it be great? Yeah.
Yes. If it can draw it out, can it put it back?
Yeah. I'm very hopeful. So as Heather said, so at this point in time, you would look at their My Health record. People will have a lot of documents on here. We're talking whole of life. A child is born, their whole life, their health summary information, every result. Shared health summaries for people whose medication is changing all the time. Filters are being built. They have some now. Medical directors already built the new filters. And as you can see, best practice even has some filters. So I only want to see the results, the DI. I only want to see the shared health summaries. I only want to see the MBS. So they have filters now, but there will be a lot of documents over time. So we'll only want to see the most recent ones. And they all stay in there. And I have compiled a list of top 50 questions that I've been asked about this in the last 4 years of training it and the way that I respond. And a question that I get commonly is, first of all, why doesn't it just replace the previous one? And my answer to that is it's a bit like your online banking. You only want to see the last transactions, but you want to know the rest are in there. So they are in there, but you filter out. So you're just looking at the most recent. It has been built with the capability for atomized information, but we're nowhere near the stage of being able to go, all of that information can now populate our software, because we don't move fast with technology in general practice. Doctors have been worried enough about just creating a summary and uploading it, let alone having their own software populated with others' information. And at this point in time, it's a gentle approach. I think it's a good idea to curate the information, having seen the state of some of the information and seen often what we're happy to print out for patients and how inaccurate it is. So the idea is to get that quality, know that it has been built like that. So when your practitioners are frustrated about it's all it does, that's all it does. I'm just looking at a shared health summary. I have to re-enter the medication. Know that if we stick with it and use it, it's been built like that, so it's possible. Whereas we start going, you can upload anything, PDFs, add anything into it, then it's not going to have that extra, benefit, I guess, to us.
We're getting very close to...
Yes. I'll let you go. I've got afternoon tea.
One question back here.
I hope I didn't miss it at the beginning, but Katrina, moving forward in regard to other functionality of My Health record, so potential to upload, chronic disease management care plans, options for patients to possibly put like a little summary about themselves to make other health providers sort of have more understanding for them, non-clinical.
Yes, yeah. So it is absolutely... at this point in time, advanced care directives, they actually caved a little and where you can put up any document you like, but you've got to do it yourself. So who in this room has one care plan in their software that everybody uses? Who has multiple care plans? Some practices I go to, everybody uses their own. I cannot get everybody to agree on one. We are trying to get the whole country to agree on one care plan. That's huge, huge. So there's a lot of clinical input into this. Please don't think there isn't. There are committees on committees of clinicians going, we would like this, we would like this, we would like this. No, we don't like that, we don't like that. 3 years it took about results, which we've only just now got. It will happen. I'm so excited about the healthcare home ideas purely because we're going to have in our software better ways to communicate that chronic condition management. So stay tuned would be my advice. And keep an eye on your software providers because they too are building additional functionality like the Best Practice Best Health app, which will bring this into the forefront in our patients and practice eyes. We're going to be seeing it more and patients are going to be sharing more. So stay tuned. Get the presentation that I spent a long time on and put a lot of links in for you and a lot of information. Share it with your practices and please don't hesitate to contact us if you are wanting to get connected and you're struggling and you have issues like the IHIs. And thank you. I've got another question.
Thank you so much, Katrina, and thank you to Heather who's left us. But it's wonderful, and I think a little gift for you from APNA, and how exciting that we're living and working in this world right now. I've worked with the Digital Health Agency a little bit, so it's such an exciting, and there's so much more to come, and it will have just great application. Do you want to talk to Katrina?
That and the website. They said they would put it on the...
It will all be on the APNA website. Yep. Thank you. Thanks, everyone. Safe travels.